morning. Good morning. And happy Sabbath. It's a privilege to be here with everyone. And on our Healthline today, I want to talk about something that I've actually been asked a few times. And because some people have asked me, oh, so actually, what do you do? When you're a cardio-oncologist, what does that mean? And so I wanted to take a few minutes to talk about what it means and how it can affect you or somebody else. Next slide. So basically, when we say cardio-oncology, it's the simple definition is that is the cardiac care of a cancer patient before, okay. Thank you. Is the cardiac care of the cancer patient before, during, and after cancer treatment, okay? The heart care of a cancer patient before, during, and after cancer treatment. So why is there a need for something like that? I think I'm going too far. Okay. Yes. So in the past, and it's not in the slide, but let's say from 1970, if you had cancer, you basically don't live long, right? You basically because there was nothing to do. But starting from 1960 to 1970, we found a medication that was really good. It's called doxorubicin or anthracycline, and that medication revolutionized the way we treat cancer patients. But what also happened at the same time was that a lot of people started having heart issues. A lot of people started having issues because we found out that this medication, apart from killing cancer cells, also kill heart cells as well. And so as you are done with chemotherapy, you are in remission, unfortunately, as you are getting older, then you have all these heart failure symptoms and things like that. Interestingly, there are people now that I sometimes see who actually have this medication and don't know anything about it, and don't know that this is the medication. What chemo did you have? Like, oh, I just had chemo. Well, there's a lot of different chemo. They are not all built the same. And so it's important that if you have a family member, a friend who has had chemo, ask them, what chemo did you have? Because this particular medication, when you take it, you may feel well. Some people have issues. About 15% will have issues right there. In the next 6 months, another 25%. But most of the people actually have issues right after. Who are the people who are having cancer, non-Hodgkin's lymphoma, children? And so a lot of times we were seeing patients who were 35 and they have bad heart. They have a bad heart. An example, and this is not a HIPAA because the patient already talks about it. He's my co-director for cardio-oncology at the UT Health. He is a cancer patient, and he advocates for this. Basically, he had cancer at 16-year-old, had this medication, had radiation, and now he's had multiple heart surgeries. He does not smoke or do anything. So again, you may not have the traditional risk factors, but if somebody you know has had chemo, just start the conversation with them. Radiation. When you have radiation, a lot of times people have had radiation radiation therapy, it killed the cancer. Well, let's say breast cancer, where if you have left breast cancer, the radiation is going to go right there. What sits behind the left breast? The heart, right? And close to the heart, the area of the heart that gets the radiation It's where the left anterior descending artery is, a big artery that supplies the heart. Layman terms, we call that a widowmaker, right? That's not a pretty name, right? So if you are getting radiation to that area, then you need somebody to follow you to know what is going on. There's other things that can happen. Heart valves. The heart valves become, there is inflammation. Radiation will cause inflammation. If you ever know somebody who have had radiation to any part of the body, what happens to that part of the skin? Becomes very firm, right? There's inflammation, but it becomes fibrotic. The same happens to the heart as well. And so that the heart valves can become very thickened, and you can have regurgitation, or heart blood, instead of going back, can come back, or becomes very tight, what we call stenosis. And we see younger patients. Again, my colleague who goes all over the place talks about this. He has had his valve replaced as well. So these are some of the reasons why it's important that we talk about this. So what do we do if you have somebody who is having cancer treatment? Again, you may go to a standalone cancer treatment therapy who may not have a cardiologist, but if you know somebody like that, say, hey, have you talked to, is there a heart effect? So part of the things is that we would undertake an assessment. What is the risk level for damage? Now that depends on your already existing heart factors. If you have diabetes, you have heart issues already, your risk level is high. If you are going to get doxorubicin, if you are going to get Herceptin, which FDA actually mandates that you get echocardiogram every 3 months, because of the ACE effect, then you are also at high risk. And based upon that, we can help work with your oncologist to see. Because some patients can't get the same dose of chemo, because you may finish your treatment, you won't have a heart left. The other one is helping patients. Some patients already have heart issues, but then they have cancer. Now, it's not going to be do it or don't do it. It's not. It's really a team approach. We have to sit down with everybody. What is the best approach for this patient? Because some cancer are so aggressive that if you say don't do anything, the cancer will eat the patient up. And sometimes some things may be able to use a second line agent that is not as dangerous to the heart. And so I'm a little distracted. Okay. Sometimes sometimes there's decisions that need to be made. But if you don't even know about it, you won't even make that connection and talk to people that need to be involved. The last one is that survivorship care. This is probably what is the most lacking in San Antonio. This is probably the most lacking in San Antonio. When I came to start the program at UT Health, the first few patients that I saw were patients that have had radiation and issues to the heart. They didn't know anything about it. The first time somebody was seeing them was in heart failure, and they were dying in the hospital. They passed away because nobody knew how dangerous it is for them to be monitored sequentially every year or every 2 years. So nobody knew enough to do that. So the takeaway point for this is that know that the takeaway point is that if you are going through chemo or somebody you know are going through cancer therapy, talk to them about it to see, does the patient know that some medications may affect the heart? Talk to your doctor, because unfortunately a lot of your oncologists may not even know about the heart. The cardiac effect of the heart. A lot of them don't know, unfortunately. Example is when I came at first, some of the oncologists like, oh, is this a good patient to refer to you? I'm like, of course, this patient has already bad heart disease. Or one example is a patient whose heart squeeze was already down at 23%. And the oncologist was asking me at that time, 3 years ago, for clearance. So I'm like, clearance for what? This patient's heart is not. And the patient, unfortunately, died about a week after I saw the patient. When I saw the patient, I asked the patient to be admitted directly to the VA because it was a VA patient, and then I got a message. So there's a lot out there that again, this is to keep you on your toes. If you have a loved one, a friend who's undergoing treatment, please make sure that they ask these questions to the oncologist. If that hospital doesn't have somebody who specializes in this, tell them to refer you to somewhere if your risk level is high. Thank you so much.